live, and we've had a busy morning already. We've talked about some of our big moves, particularly on our move towards home first, and in particular our work on carbonisation and some of the really class leading within the NHS activities that are being undertaken in both of those areas. We're also joined by a colleague, Richard Spencer from E.ON, who talked to us about some of the work E.ON are doing with the Queen's Medical Centre over in Nottingham, which was interesting. And we were joined by the Chief Finance Officer of UHCW, UHCW being the pathfinding organisation within the Coventry and Warwickshire ICB to launch the new Oracle EPR system. And we talked about some of the very real challenges they're having and how we can learn from their experience. So a busy morning already. But we have a series of apologies of absence from today's meeting. First of all is Adam Carson. Adam, if you are watching this digitally, we wish you a speedy recovery. And thanks again to Sophie Gilks, who's standing in for Adam whilst he is unwell. We have apologies from Tony Bramley, Fiona Burton, who at the moment is on holiday, I think doing the 100 squat challenge a day in India. So Fiona, I hope that's going well. But Ellie Ward, thank you for deputising for her. We have apologies from Lucy Flanagan, Harkamel, Jack Foster is deputising for Harkamel. Apologies from Helen Lancaster, who's on long-term sick. So Chris, really appreciate you standing in as interim Chief Operating Officer over at Worcester. And Tracy, good to see you as well. And Zoe Mayhew, apologies from her over at Swift. David Moon, Joe Newton, and Emma King's kindly deputising. And we have apologies from Katie Osmond, and Susie Jobins is deputising for her. So without further ado, any new declarations of interest? Could you please raise a digital hand for me, please? Okay, so first up is Ellie.
Thank you. So as I'm Acting Chief Nursing Officer in Fiona's absence, I've refreshed my declaration of interest, and for transparency should declare I'm married to a consultant anaesthetist at Swift.
Congratulations, Ellie. Thank you. And Kim?
Just to say that I've been appointed as chair of the management board for 360 Assurance, which is our internal audit service.
Okay, fantastic. Thank you, Kim. Simon Murphy?
Oops, get the microphone on. Just to let you know, I've been appointed as a trustee of the Regional Advisory Board in the West Midlands for the Canals and River Trust.
Okay, thank you, Simon. I know Anil, I think, has previously done work for that organisation as well. And Bharti Patel?
Yes, thank you. I've just recently taken up a position as non-executive director for a GP group of practices in Dorset called the Castleman Healthcare. Thank you.
Okay, super, Bharti, and I'm sure that will be very useful. And for my own sins, I have retired as chair of Your Cherished, a wonderful charity operating around Sutton Coldfield and North Birmingham, helping young teenage girls in particular with issues of trauma or self-harm. So I have retired from that position. So without further ado then, the last set of minutes of the meeting held on the 7th of August, if there are any adjustments to those minutes, could you please raise a digital hand for me, please? These have all been through the individual boards for members of the public's benefit. So I can't see a digital hand raised, so I'll take those as correct and we'll duly sign them. So if we then go to page 18 of the 94-page pack we have, in terms of the action points arising, the first is for the Foundation Group Strategy Subcommittee for Chelsea to amend the attendance record. That was done. Thank you very much, Chelsea. Then on the Foundation Group Performance Report, Adam's taking away to look into the Swift 52-week weight position. That's now been included in the IPR. which went back to the SWIFT board on the 4th of September. Thank you in abstention, Adam. And then Catherine was going to provide an update for why George Eliot was an outlier for cancer diagnosis. Just for all of us on this one, Catherine, can you just brief us on what's in the comment section, please?
Yeah, so I think when we've looked back at the data collection, we undertook an audit, I think in August, and looked at the way the data was collected. We found some challenges with that. That's then been corrected so that we are collecting these cancer attendances in the emergency department correctly. And we've changed that to a standard report that's now going through our cancer board, and will report up through our governance structures in the quality and safety meetings up to QAC, so that George Eliot board can have assurance on that going forward.
That's great. Thank you, Catherine, and thank you for your hard work. Any questions or perspectives to Catherine on that? Okay, I think that's all the matters arising, but if colleagues feel I've missed a matters arising, could you raise a digital hand for me, please? Okay, on the agenda, it's then got the update on the overview of the big moves and key discussion from the Foundation Group workshop, which I covered off earlier. But Glenn, is there anything you'd like to add?
No, I mean, probably just to reiterate what you said, Chairman. I think particularly the carbon reduction big move was a, we set ourselves out to be kind of leading the NHS on that one, so it was quite ambitious. But it's really good to see the amount of work that's going on across group and the sharing between the parts of the group on how we can do that better. And then similarly with the Home First big move, obviously this plays into the new long-term plan for the NHS and the DARSI work, and it's how we pull off that emission prevention and discharge speed challenge. Again, some great innovation in parts of the group that I think there's something for me about making sure that we implement all that best practice across all parts of the group. Obviously, there's a bit of an ongoing discussion with our partners in Worcestershire about how we can ensure that we've got some of those, particularly exit pathways, in place. And so it's good to see we're trialling a couple of new approaches there also. So really good to see all of that.
No, great. Thanks, Glenn. Okay, team, we'll move on without further ado then. And we will move into the Foundation Group performance report and the performance review and updates, which is led by our managing directors. And I assume we're going to do them in the order in which the columns show. And so without further ado, Jane Ives.
Russell, and good afternoon. I usually start with some concerns and then some things that I'm proud of and worried about. In terms of concern, it's really still around the ED congestion, but I'm not going to say very much about that because that's later on the agenda. So I'm going to talk really and pull out the issues around productivity improvement, where there's further opportunity and what the impact of that is across Wye Valley. So the first part of that is around outpatients, and we've made some really good progress on utilising our outpatient clinics. So this is the number of clinics we've got available and how many of them we use. So that's gone from under 80% to now we're at 90%. It's been a really big piece of work and a big project. Really what it means is that everybody books their clinics 6 weeks in advance. So rather than booking your clinic for the whole year, and then if you're not there, it can stand fallow. We're utilising all of that space much more effectively. So that's been a really big change, and it's been really impactful. The other part of outpatient productivity that we're looking at is around PIFU, which isn't going quite so well. So this is patient-initiated follow-up, where we rely on patients to come back to us when they're ready rather than keep booking them routine follow-up appointments. We're not doing as well on that as we want to, but we've got quite a big change coming to our EPR system at the end of November, which really means we've got a much better safety netting of patients who we discharge to PIFU. So there's a number of our higher risk specialties with patients on particular drugs, things like rheumatology and cardiology, and we'll move a number of specialties onto PIFU at that point. So we're expecting quite a big improvement to come. Theatre productivity. So we've hit 80%. I think that's the first time, which is really good news on utilisation. Still got further to go. But what's also really impressive is the number of cases per list. So since putting in the elective surgical hub, and that's with those sort of high volume lists, we've moved from 3.2 patients per list on average to 3.8. So the result of all of that is if we look at our number of patients who are waiting over 52 weeks, that's halved in the last 12 months. And by the time we get to the end of this year, it should have halved again down to 500 patients waiting over a year. So that's still a lot of patients waiting over a year, but it's a really significant improvement. And then the other thing I'd really draw attention to then is the cancer performance, which is part of that productivity work, but also part of sort of really careful pathway management. And we've got some really solid performance around cancer. And I've just had our September data, and we're at 78%, both for our 62-day pathways and for the 28-day faster diagnostic standard. So some really solid improvements over time, and we expect those sorts of levels to be maintained into the future. Again, still further to go. You know, our target used to be 85% for our 62-day pathways for cancer. The target we're aiming for at the moment is 70 as everything recovers from COVID, which does feel like quite a long time ago, but some of those have very long tails on them. So the target for this year is 70%. So we're well above that, but aiming to get back to that 85% target again. So those are probably the things I wanted to draw out, Russell.
That's great, Jane. Before we move on, any questions or perspectives to Jane? Okay, so sorry, Glenn.
Sorry, I was a bit slow on the button. Yeah, one of the things that Jane and I have talked about is this increase in elective capacity and the use of our core capacity through fewer cancellations. It's obviously making a big impact on reducing the waiting list, but hopefully there'll come a point in the future where we're back into an equilibrium level. And I think there's then an opportunity to reduce the use of the independent sector in Herefordshire through that capacity. And I think that's a bit of a challenge set ourselves for a few years now, but it's starting to feel like we've got the right level of capacity in place, but we're going to do some work just to assess that.
That's great. And Susie, and then we'll move on.
Just to come in on that, so we've just been having conversations with the independent sector about what we're going to utilise for this year, and we've been having further conversations with the ICB about a sort of a 2 to 3 year programme on that very point, Glenn, as to how we move away from that reliance of the independent sector. At the moment, we've got that challenge, it's in certain specialties, but as we move through and we get back to that equilibrium, that's absolutely where we intend to be.
Just one question on that, Susie, and educate me again. What's the pricing like when we use the independent sector? Is it the same rate we would get paid on a tariff basis? Or is
yes. Yeah, so we pay them tariff, which is unfortunate because we would like to keep that contribution ourselves. So that's the prize, Russell.
Exactly, that's the prize for us to go after. Okay, without further ado, in terms of prizes to go after, Sophie, for Swift, please.
Thank you. So similar to Jane, I'm not going to touch on urgent care or the workforce. We're just going to touch on the weights, cancer performance, and then finish on our theatre utilisation. So in terms of the weights, our 52 weeks are steadily reducing. Do need to flag, and the Swift board in particular have heard quite a lot around orthodontics and the continued issues and concerns that we have in that area. We are working with the ICB and the West Midlands Commissioning Unit to identify the alternative providers, but it does still remain a concern for the Trust. There is a regional review about to start as well around to scope that service for the future, because we need some more medium to long-term plans in this area. But importantly to note, I think, is that we have also briefed Health Watch. The importance of that is so that they understand the position and what's happening, so they're able to speak with our residents if they're going to Health Watch with their concerns around that. In terms of cancer performance, just wanted to bring out, speaking to Sarah Lee, that in terms of our 28 faster diagnostic standard and our 31 days target, we are expecting to meet the national targets in October. 62 days is more of a challenge, and we continue to see improvement in that target. However, we've recently done some work around urology and gynae pathways, and we hope to see that impact and give us further improvements as we go into October, November. Diagnostics and pathology continue to be our main concerns around some of the delays. And then finally, I guess the thing we're really proud of to flag here is our theatre utilisation. So we have hit 86.4% since this report was produced, which puts us 5th nationally in terms of that utilisation. Nikki Mills deserves quite a shout out. She's gone into there and looked at the processes and worked with the wider team to help us achieve that. And that then will be monitored through our Excel and everything, but it's something that's really driving an improvement around the utilisation of our theatres. And again, our late starts puts us in the top quartile. So really proud of the teams for the work that we've done in that area.
No, it's super. And I think just for each of the managing directors, it's worth shouting out about what our elective activity is running like at the moment. Very roughly, correct me if I'm wrong, it's about 125% for Wye Valley. It's about 110, 112% for Swift. And if I can ask Catherine and Stephen to give their own numbers, that would be great. Questions and perspectives to Sophie, Glenn?
Yeah, and just so public understand that metric, that's compared to our pre-COVID level, so we're doing more than pre-COVID. I think it gets even more interesting when you look at trust to trust comparisons today, actually, which I'm encouraging the national team to do. Just a couple of observations, Sophie, on what you said there. I think the diagnostic weights linked to pathology, it would be good to maybe have a little bit more of a look at those at Swift board next time. There's some ongoing work, as board members are aware, and looking at the pathology network. So it's key to ensure we have effective turnaround times in those areas. And then the long-standing orthodontic waiting times issue. I have reached out to Professor Briggs, who's the national lead on elective recovery, and I think he's bringing along to talk to us the dental lead nationally on getting it right first time, just to see if there's anything more they can help us with. But this is a problem that's much bigger than South Warwickshire, because we found ourselves last man standing in terms of delivering that service to a much wider catchment area. So hopefully we can find a solution.
No, absolutely. And Ollie's Hisco mentioned in the chat box the issue of the high 28% fit for discharge number. The whole issue of medically fit for discharge and the delay between being medically fit for discharge and actual discharge is a real system challenge both across Coventry and Warwickshire and Hereford and Worcester. And just for members of the public, keeping people in the acute hospital setting when they're ready to go home wastes taxpayers' money, and therefore we are absolute advocates of home first, and we'll do everything with our systems partners that we can to ensure that happens. In terms of other questions and perspectives, Paul?
Just an observation to Sophie, the improvement in late starts in theatres over a month period is absolutely incredible. Is there some learning we could put in place across other hospitals in the group? Because that is one thing which might impact on the number of patients that are seen in a theatre list and therefore productivity. I just think that's an incredible improvement to go from sort of below 10% to 60%. And I'm assuming that means that, performance in that is going to carry on in that direction. So just an observation about learning from that.
Yeah, I was just going to say, we've actually got the team coming to talk at Swift's Open to Change around the whole piece of work. So we'll make sure we extend that out to the wider group for that particular improvement board.
Okay, thank you, Sophie. And like I said, thank you for standing into the breach and all the work you're doing. Next up, we've got Catherine at George Eliot. Catherine.
Thanks, Russell. So I will talk a little bit about emergency performance. Our 4-hour standard remains pretty similar at 74.6%. That doesn't change very much month on month, but what we saw in September, after a slight reduction in the number of people that were being delayed 12 hours after the decision to admit, that started to climb again in September. And again, you can see that our ambulance performance in terms of the turnaround in our ambulances or ambulances waiting over an hour increased again in September compared to August. And it's so important that we consider carefully the paper on the use of temporary escalation spaces, because we are boarding patients on our wards more days than we are not, and that is not the standard of care that any of us want to provide for our patients. So really important. That paper is on the agenda later. In terms of our cancer performance, that's an area I want to flag an improvement. In terms of our faster diagnostic standard, you'll see we're at 76.7% there. That's around mid-table. And you can see organisations like Worcester, don't want to steal Stephen's thunder, but organisations are now exceeding 80%. So that's where the best performing organisations are and where we would like to get to. In our 62-day performance, we were earlier in the year at the bottom of the table in the Midlands for our performance around 62 days. We're now 6th in the Midlands with a performance of 72.9%. So that's a real improvement, and that has been sustained now over a number of months. So I'd like to thank the teams for the hard work that they have done. And as Jane says, that's not where we want to be stopping. So we will continue to work on that for that important group of patients. Another area I want to celebrate is on the 65-week performance. So the national standard was to eliminate 65 weeks by September. And thanks to some really hard work, particularly among our surgical teams, we were able to report no patients waiting over 65 weeks at the end. It was a bit of a chase to the wire. And breaking news for October, we had one breach of 65 weeks because the patient couldn't accommodate the date that we had offered them. So that's really good news, although again, not where we want to be resting on our laurels. People are still waiting, as you can see, 229 patients waiting over 52 weeks, over a year for treatment. So there is more to do on that. And he wanted to know how we were doing on our elective performance in terms of our elective, so inpatient operations compared to 1920. We did 175% of the inpatient operation work compared to 1920. We were behind on our day cases, 95% on our day cases, but that is in part prioritising inpatient operations to clear that 65-week wait, and 109% in September on our outpatient first appointments. And we've seen that improve further in October. You will see in our theatre productivity, we've dipped from a high in June, and we had some problems with flooding in our two of our new theatres, not old theatres, new theatres. So to achieve that level of performance with that level of disruption during the month of September and into October is a real testament to the hard work that our teams are doing to improve access to care for patients. But you will see that our number of patients on an open pathway, our RTT performance, is still lower than it has been. And I think that's an area that's going to possibly become of national interest, looking at how is it that we're doing more operations, but the waiting list is not reducing as a consequence. And that's something that we're doing some more detailed work to understand. So that really is what I want to say from the George Eliot performance, Russell.
No, fantastic and stunning performance in terms of elective inpatient work, and I think it will be exciting for the Swift team when we are able to get our elective hubs open. Any questions or perspectives to Catherine? Stunned everyone into silence there, Catherine, with the great performance. Really well done, team at George Eliot. Really, really proud of you all. Thank you. We'll move on then. Last but not least, Stephen.
Yeah, thank you and welcome everyone. I'm going to pull out 2 or 3 things, but there's a bit of a theme that follows from everybody really. I will talk a little bit about urgent care before we lead into the discussion around winter planning and escalation areas. So that's our biggest area of focus and our biggest area of concern. Really, 2 really key areas that we're focusing on is the long ambulance waits that we're experiencing and the long time of patients in the department moving through to get to a bed. What you'll start to see through the report for this and the following months is a reflection on the impact that both the Akenbury Zero Works and the flooring have had. So we've had to decant ED at various points and it's been over 2 floors, which has caused some issues. But the other one that we are focused really with the system on, to put some context behind those numbers, is our long length of stay of over 21 days over a quite a substantial period actually has increased, and we're currently around 150, whereas previously years ago it would hover around 50. So there's quite a substantial bit of work we need to do with the system to improve on that.
Stephen, can you just say that again, just so that members of the public fully absorb what you've just said? Can you say it again, please?
So we've got in the trust, we've got around 150 patients that are waiting over 21 days.
So they've been in the hospital for over 3 weeks.
Yeah.
They're mostly medically fit for discharge.
Yeah.
But they're staying in the hospital at roughly 400 quid a night, whereas they could be at home or in a more appropriate, cheaper setting.
Yeah.
Thank you. Back with you.
Thanks. So you'll see when we look at particularly some of the mitigations we've got through winter, how we're trying to tackle that. And Sarah's leading a big piece of work for us, and Jules is leading a piece of work around long length of stay. People have mentioned, so one of the things that we have been improving quite significantly is our cancer performance. We are hopeful that with all of that working that we will be exiting tiering arrangements, but that's one that we have to wait confirmation from NHSE, but we're hopeful of that. The other one is around our productivity and our RTT improvements. So we've been running around 125% is the figure. And the significant work that the teams have been doing around what we call right site, right surgery. So particularly what's driving that underneath is the maximising of the Alexandra Hospital and the Kidderminster site. And there's still further work that we're concentrated on going there. And there's been some really good kind of external visits and feedback about where we are going with that, not only from GERF, but also from paediatric accreditation as a surgical hub as well. And there's a lot that we think we can really drive at that. So it's kind of a similar theme. The other bit I would pull out, which kind of is some positive, because when you're dealing with a lot of the challenges we're dealing with, you need some positive, is if you look, they're not on there, the financial figures, but if you look at the reduction in insourcing the trust has managed to do and drive that elective improvement, that's quite significant. We've virtually eliminated most of the insourcing that we had. We had a really heavy reliance on it. And I think similar to Wye Valley, one of the bits we'll be looking for strategically is how we then carry on that improvement and then look at what's going to independent sector or neighbouring trusts, particularly up in the north. So that kind of sets a path out that we're looking to exploit over the year. Happy to take any questions, Russell.
That's great. Any questions or perspectives to Stephen? Glenn?
Yeah, I think you're absolutely right to highlight the long length of stay problem and look forward to seeing how that work develops. I think the other area, though, when you look at the data, is the very short length of stay, and there does seem to be a bit of a drop off in SDEC numbers, same day emergency care numbers. And then when you look at the zero length of stay on general and acute wards, that seems to be higher. So it's almost like patients could be in SDEC, but they're going into the ward base. It may be that the data's confusing me on that one, but that does look like an opportunity.
So do you want to respond to that before I go to Francis?
Yeah, I think there's a couple of things that we're exploring with that. So one is we recently brought a lot of the SDECs together, and I think we're really pushing them on their acuity of what they're taking. I think now they've got a home and embedded, we can really, really push on that. I think overall there's a general silting up kind of because we're dealing with those big numbers. So it's just taking that whole bit of capacity to kind of deal with that. So hopefully with the winter plan that Sarah's got a hand up on, probably explain, we can free it up a little bit. That's the plan.
Sarah, do you want to come in before I go to Francis, please?
Yeah, thank you. It was on Glenn's point, actually. So we've just had the 45-minute steering group, and I talked through with them the dashboard and the SDAT performance for the other 3 trusts in the group. And what we've agreed, Glenn, is that actually Chris Douglas is going to reach out to the clinical leads, certainly for the surgical SDATs across the group. Because I have to say there is a little bit of pushback and challenge from certainly surgical colleagues about expanding out the criteria. So we're going to look out to the group for some support around that. So we'll have conversations next week.
That's great, Sarah, and thanks, Chris, for your support in that. But it evidences again the benefits of the foundation group. And Francis?
Thanks. And probably rather we have the discussion a bit later, but just not to lose sight of the discussion that you brought Stephen back to about the number of people waiting a long time and the impact that that has both on people who are trying to get into a bed, and there isn't one because somebody is there, but the big issue of hospital-acquired functional decline and the long-term consequences for people who spend longer in bed. And I think a reminder for the public that hospital is a really, really great place if that's what you need, and it isn't the place to spend an extended length of time if you are well enough to be in another environment, preferably home, but if not in a less clinical environment, hospitals are not a good place to spend a long time. So looking forward to the discussion later in the meeting.
Yeah, I couldn't have said it better myself, Francis. Thank you. Any other questions or points to Stephen? I'd just like to make a general point to my executive colleagues at Worcestershire, having now been chair there for, I think, about 14 months. I can't say more strongly how impressed I am and proud I am at the pace of progress and turnaround you are achieving. We've still got a long way to go, but you're doing very, very well. So Stephen and team, thank you for your endeavours. You know, I think there are learnings for other bits of the NHS about how quickly failing organisations can be turned around with the right leadership. So thank you, well done. Okay, team, we'll move on then, as Stephen has sort of indicated, into the winter preparedness update and the use of temporary escalation spaces. And just before we start off on this, the point that Francis made about long length of stays and the point I made about how many medically fit for discharge patients there are. If we have bed blocking because people aren't able to get home, the inevitable consequence of that for many of our UECs is they cannot get patients out of the UEC, the accident and emergency department, as quickly as they would like, because they don't have a bed to put them in. And that's when boarding occurs. So we are having to open up across the foundation group surge capacity at a very expensive cost to us in terms of agency nursing and overtime, when if we were just able to make flow work better with our system partners, we would be able to get people home into the right medical setting for them, save money for the taxpayer, and reduce boarding and surge capacity. So with that sort of contextualisation as to the way flow works, my COOs and CNOs, over to you.
Thank you, Russell. When he is going to ably assist me in sharing the slides, I'm going to start off this section of the board. I'm going to look at the approach, the challenges and plans. Then I'll hand over to Natalie, who's going to talk us through the use of our temporary escalation spaces and the quality and patient experience. And then Robin will finish off looking at some of the impact of our winter plans, what the remaining risks are, and the other pressures and group-wide learning. What's interesting is we went through these plans as a group is how our plans are aligned, very similar strategies and very similar themes across all 4 organisations within the group. So first slide, please, Gwenny. So ED attendances is part of our preparation for the winter, and part of our submission for our winter plans was the modelling of our ED attendances. We can see here 2 graphs showing our overall year-on-year increase across the last 2 winters of all types of ED attendances and type 1 ED attendances. Our activity levels have remained the same or high for the last few years, and we're again predicting this year to remain at similar levels, if not higher. What's different over the last couple of years is we have seen attendances into our EDs over the winter increasing, but remaining the same throughout the summer period. And we've seen that this year. So attendances increase at the winter, remain the same, then step up again in the preceding winter to a new norm. But we've also seen this year acuity across all our EDs remaining high all year round. Next slide, please. So our overall plans, all 4 trusts have been focused on 3 main areas. That's improving flow, reducing demand for inpatient care through new and different pathways, and expansion of our current schemes, system support and ownership and accountability, and as you already mentioned, Russell, reducing congestion in our ED department, particularly focusing on starting a day right by reducing the number of patients who require an inpatient bed and have a decision to admit at 8 o'clock in the morning. So looking at some of the themes, site capacity, all 4 trusts are looking at our roles and responsibilities of our teams, making sure the right accountability and escalation levels are right within all of our teams. Swift are looking at digitalisation of their bed management system, and that's one thing that I'm particularly interested in, is that's rolled out. And then safer care bundles and the implementation of patient safer care bundles. So that's a senior review across 7 days of the week by midday, all patients having a good estimated discharge date, flow pulling patients from ED into assessment areas by 10 o'clock, early use of our discharge lounge, and MDT reviews of all our long length of stay patients and stranded patients on all our wards, ensuring that patients who do not meet the criteria to reside are at the heart of understanding of our barriers to discharge. In terms of capacity, all the trusts are focused on increasing areas to maximise our capacity in our inpatient and community services, such as SDEC expansion, whether that's increasing capacity, hours or resources, and virtual wards, new pathways, expanding to other specialties as well. And then fourthly, system partners, involving in our discharge planning and capacity and utilisation, implementing single points of access within the system, so increasing the ease of being able to access the right service for our patients at the right time, and focusing on call before convey, so increasing call before convey from crews, paramedic crews on scene, but also increasing the categories of calls that are being streamed across to our urgent community response team, so we can make sure that there are alternatives to admission to ED and that patients are cared for closer to home. And that at each place level are undertaking a winter review of last winter, and that's formed the basis of all of our plans as well. And then continue to engage with our partners about what schemes we can implement next, particularly when funding or opportunities arise. Next slide, please, Gwenny. And then some of the challenges I've already mentioned about increased ED activity and acuity. And Russell, you already mentioned the impact of medically fit for discharge. We saw this morning's presentation at our board workshop how we've seen some sea change shift in pathway in home first pathway 1 delayed patients across all of our system. However, in Herefordshire, we've still got some issues with in terms of PALIS delays for all of our pathways, including pathways 1. But we are seeing a sea shift change in pathway 1, 2 and 3 still remains a challenge. Along with that is the lack of transparency within community capacity, and that's ensuring that we're working with system partners to help them manage in the length of stay and overstayers on community pathways. Very similar to how we manage length of stay and stranded patients within our own acute and community services. And then workforce. Some of the challenges there is around our workforce. As we know, our workforce have had no respite since COVID, and although they are managing extremely well, they're at the cutting edge of leading a lot of our new and innovative schemes. They're still coping with the recovery of our urgent and emergency care pathways and that improvement that we spoke about earlier in terms of our elective work, the impact on their morale and the impact on the ongoing pressure cannot be discounted. And then additional pressure is improving our handover process for our ambulance colleagues. We all know that we need to improve our handover processes in ED, and the regional rollout of zero tolerance on 45-minute rapid ambulance offloads will be faced by all 4 of our trusts, and we need to make sure we've got our ED and escalation processes right. But it does come back to our YMAS colleagues supporting us with call before convey, and also reducing the amount of intelligent conveyance that some of our trusts are faced with. Next slide, please, Winnie. And then, so what are those plans? If you read through, I'll let you read through here the various schemes that each of our trusts are implementing. But as I said before, they're all very similar in what we are aiming to achieve here. Very similar common themes. One of the things that we've done across our trusts is a point of prevalence audit, so ensuring that the right patient is in the right place and in the right bed, and steady progress has been made there to ensure that an increased number of our patients are in the right bed. And also looking at some of the learning across our system to inform our plans going forward. Next slide, please, Gwen. And then, as Catherine has already mentioned just now, the ongoing use of escalation and temporary escalation spaces across our foundation, from that foundation group. Despite our plans being implemented, we still continue to use high cost temporary escalation spaces and boarding patients in beds, which impacts on quality of care and cost. These numbers do not include those patients that are waiting in our ED departments at 8 o'clock most mornings awaiting beds, but we continue to use high level of escalation beds and boarding patients right the way through the summer period. And all of our schemes are aimed at reducing that as far as we operationally can. I'll now hand over to Natalie.
Thank you, Andy. And if we just stay on that slide for 1 second, sorry, it was just to mention that our priority is to reduce the amount of use that we have of that corridor care, particularly the graph on the right that doesn't include, as Andy said, the number of patients at any time waiting in ED, but also for the boarding of patients in the non-designated bed spaces and through the improvements that Andy has just spoken about. But whilst that is being enacted, our priorities is to ensure the safety and the quality of care that our patients receive. So next slide, please. So over the past few years, we have seen a national rise in demand and the requirement to use every space possible. This has seen a rise in suboptimal care, which has been depicted in the media and on recent programmes such as Dispatches. In response to that, NHS England have set out principles for providing safe and good quality care in temporary escalation spaces. But this should not be normalised and should not be counted as standard practice. These spaces are not the same as the escalation beds, which are planned and which do have the designated resource areas, equipment, and particularly used generally during the demand of increased during winter. But as we've just mentioned, that demand has continued continuously through summer, winter, and over the past years. So the 6 principles that have been set out by NHS England, as you can see on the slide, are under the areas of assessment of risk, escalation, the quality of care, raising concerns, the data collection and measuring of harm, and the de-escalation of these areas. And what I'd like to say is that we've pulled together from all 4 organisations in the foundation group what we currently have in response to these 6 areas. And you can see quite an array of elements that we do, but also, as Andy's mentioned, we do the same across the trusts and through the foundation group to ensure that we are picking up on any areas. So each of our organisations has an assessment of risk. That's not only for the environment, but also for the inpatients, and which patients are able to be boarded or the corridor care, and we do have an exclusion criteria in all of our areas for that. And each of those assessments is within a standard operating procedure, protocols and policies. Our escalation processes are very similar across all 4 organisations, and we have various meetings, have slightly different names in some areas, but all 4 have exactly the same. So at all stages throughout the day and out of hours, we have the ability to escalate and any areas of concern. The quality of care is obviously critical and very important to us, and to ensure that we are undertaking that quality and the safety for our patients, we have different methodologies and ways to escalate and ensure that we're doing that. So the privacy and dignity for our patients, we have hourly rounding, be that in ED or within the wards. All patients have access to nutrition, hydration, elimination needs, and the importance of sleep. So you can see those there. A raising of concerns not only for our patients, their family and carers, but also for our staff. If there are any reasons whatsoever that anybody is concerned for any delivery of care that is being undertaken, we have methodologies across all of the organisations to be able to do that. And also we've started to undertake, and we will listen to the voice of our patients and our families. So spot surveys, employing the likes of our volunteers and our forums across the organisations that really support us in being able to hear what our patients are saying, and for us to enact and to listen to that. The data collection we have through incidents, through PALs, through complaints, through safety incidents, through generally chief nursing officer reports that go to all of our quality committees and up to board, and our integrated performance report, as you've seen earlier. And also important is the de-escalation. Do we have the ability, have we got that right to be able to look at the triggers and be able to de-escalate? So these 6 principles have been developed to support staff to deliver the safest and most effective care possible. And this slide hopefully demonstrates what we have in place across the foundation group, and the assurance that we can give to the board and the quality assurance boards on the delivery of care is being reviewed and monitored. Next slide, please. Okay, so this is just a reiteration on the left-hand side, particularly from a patient experience point of view, what we have in place, and also for our escalation and our raising of concerns. And as I've already said, patient safety and ensuring the best care possible is what we all strive for, and particularly for patients in non-designated bed areas. The patient voice and experience and outcomes are very important to monitor and listen to and review. And I've previously outlined how we do this through our quality assurance mechanisms and how we are doing against the 6 principles. On the right-hand side of this slide, you can see to date, from year to date, the number of incidents that have been raised, and this is collectively across all 4 organisations. The number of formal complaints we've had from patients or families, which I must say is very low, considering the first slide that you saw, where you could see the number of escalation boarding patients that we have across the organisations, and also the number of concerns, and that's generally through the PALS service. The reason for mentioning earlier some spot surveys and making sure that we have the voice of the patient is because what we are seeing, and it could be because we're explaining it incredibly well and the communication is good, is the number of complaints and PALS concerns are low. But we need to do that spot check to ensure that we are gathering the intelligence from our patients and from the families to ensure that we are getting it right, and if there are any improvements that we need to make. So those snapshot audits, I think, are really critical for us going through this period, and helps us to improve upon our care. And I'll hand over to Robin.
Yeah, thanks, Natalie. If we can go on to the next slide, please. So there are also other risks associated with the use of temporary escalation spaces, and they also stretch into the impact on our finances as well. So there are increased demands on our staff that we know about, that pushes increased expenditure on bank and agency costs, impacts on the morale of our staff, and retention, of course, we talk about all too often in board in terms of how do we retain our staff. This does not help. And also drives increased levels of sickness. So all of these metrics we monitor regularly through our governance structures, but they all potentially have adverse impacts from the use of temporary escalation spaces. And likewise on some of the quality safety metrics that we monitor in terms of patient experience, complaints, length of stay, etc. If we can move on to the next slide, please. So in terms of the psychological impact on our teams. We know our on-call teams, our directors on call, our managers on call, and our clinicians on call. Through the winter months, we know the intensity of that work, the number of times they're contacted, that increases. That also has health and well-being related impacts for that staff group or those staff groups. Likewise, our staffing establishments also puts a strain for the points raised there in terms of decreased uptake on locum and agency shifts or the lower morale of the teams, and also not to mention our teams do not want to deliver patient care in corridors or in any of these patient escalation spaces. They want to deliver care in the environment as it's designed, and it's designed that way for a reason. And we're really working hard with the teams. The temporary escalation spaces aren't to be normalised in any of our areas, and that's the reason for the focus in terms of every day driving patient flow through our current capacity. And also we've got to acknowledge the fact that there are other elements of maybe not getting the basics right. So we know there are regular frustrations on all sites around car parking, a lack of 24/7 food availability on site, and also the key with this is to really focus on the communication and explain to our teams why decisions are being taken and what that means to them, and creating a more positive environment. Have the next slide, please. We've also got to remember that the additional pressures that we've talked a lot about already today, both in workshop and in board, they don't go away. So there's still a need to maintain elective recovery performance. There's still an intense scrutiny on all elements of performance and productivity at all levels. So that is still a driver within the organisations and an expectation. Likewise, we talked earlier on about our certainly for George Eliot and Swift in terms of our preparations for our electronic patient record implementation over the next 12 to 18 months. And also we know that our sites have got various stages of estates work that are critical to be performed. And we've already heard from Worcester in terms of the work at the Alex in their ED for the flooring and fire protection work that's needed. So all of those put further strain on what is already being seen as a busy winter period. Also, on top of that, we've got things like annual planning rounds that we do for with one eye on 2025-26, and also the cost and financial trajectories, how we continue to deliver against the expected trajectories. So if I could have the next slide, please. So throughout this, there's still, despite our best efforts, there still remains risks associated through winter, despite our best efforts and the use of the funding envelope to put additional services in place has been identified within each organisation. The commonality across all of our organisations in the group is that the reality is that there may still be a potential need for increased capacity for inpatient care. It may also impact on our ability to deliver elective activity. There may be a risk that we struggle against our financial targets for everything I've just said, which all has potentially an adverse impact on the quality of care delivered, which is again the focus of Natalie's slides. We know that ambulance offload times are key for us to maintain, but again we know that as our sites get more congested, that also has the impact of increased ambulance offload times, which also is linked then directly to the risk of ED overcrowding. And likewise, the requirement for some of our more critical areas of care, such as critical care, intensive care, CCU, cardiac units, etc., for those really acutely unwell patients. If I could have the next slide, please. So finally, just to pick up on the learnings across the group, what we can be clear on is that it's really, really useful to have clear evaluation and tracking of the impacts from previous years, and also the ongoing impact of current year plans for the winter, so that does inform future years planning and help us to shape the future. And likewise, in terms of our communication as well, we really need to communicate clearly with our teams right the way throughout, and also our patients, and linking with our partners to ensure that there's clear communication out to the wider public about the strains or the things what we need people to do or how to interact with us. And likewise, being agile with our winter plans. We know we've got a limited winter envelope and winter funding provided in each of the systems, and it's about making sure we hold in the wings prioritised lists of things, other things we could do should more funding become available that may well also be of benefit to us, and those things we remain agile in order to be able to bring online quickly. And I think the final 2 points are linked around the collaboration and maintain conversation and communication with our system partners, whether it be in place-based, whether that be with NHSE or ICB and within systems. This is a collective effort, and it needs, as we say time and time again, it needs all partners to be working together in alignment to deliver the best care for the patients who need our services throughout the winter. And I'll stop there, Russell, and take any questions.
No, really great set of slides, and thank you, colleagues. Really supportive things in the chat box just for you all to have a look at. Questions and perspectives, Glenn?
Yeah, it was really good to see how that touched all bases, actually, particularly to see chief nurses alongside the chief operating officer. I'm sure if the chief medical officers were involved in it as well, they would be saying similar things. So I think it's that kind of shared ownership of risk and flow there. And actually, when you look at the complaint levels as an indicator, an average of about 3 complaints a month over group, where we're looking at about 40,000 A&E attendances per month across group. It kind of brings it home as to how well people are managing these risks. But obviously, as we implement the 45-minute protocol, that will bring with it some different judgments about risk. It's being implemented because, quite rightly, the riskiest patient in the system is the one that's at home waiting for an ambulance. So it's right that we free the ambulances up by offloading rapidly. But I think the other bit that we've just got to be mindful of is that we don't create all of that risk around the front door of the A&E, and we actually think about whole system risk, because as we've already spotted elsewhere in the hospital, in a bed, there's an older person who wants to be at home, who could be at home with a relatively small amount of support, and as Francis said, is actually in a higher risk situation by staying in hospital. So I think I just urge us all, as we manage this winter, to try and ensure that all parties in the system take a balance of risk, including some of those patients who could be at home more rapidly.
Well said, Glenn. Catherine?
Yeah, thanks, Russell. I mean, in part, I want to reiterate some of what Glenn's saying about the 45-minute drop-off. But first of all, what I would say is that some of this presentation has been built around the guidance that went out to all organisations around the use of temporary escalation spaces. And it's really comprehensive and great to see the amount of work that is going on to keep patients safe when they are not in the right spaces for care, whether that's in a corridor in the emergency department or as an additional patient on a ward. And our teams go over and above trying to keep patients safe in the most difficult of circumstances. So it's great to see the comprehensive thing there. Sometimes for board members, this can be quite esoteric or a piece of paper, and one of the recommendations is about making sure that boards understand and talk to patients about this. So Julie and I went down when she visited as part of the NED walkabout to go and talk to patients and their families who were experiencing delays in our emergency pathway. And I would encourage all board members to make sure that we make this real for ourselves. It's not just a report, but we talk to patients and their families to understand what this means in practice for people. And then in terms of the 45-minute drop-off handover, I do recognise what Glenn has said and completely believe that with every fibre of my being, that there is risk in the community and there is risk when people are held on the back of the ambulance. But what we are experiencing is an extremely overcrowded emergency department with all of these extra capacity spaces already filled, and then taking additional undifferentiated patients into that is really ratcheting up the level of risk in an emergency department. And Russell, you've mentioned several times about the need that we have got both to work with our partners in the community, and so much work going on there, but the pace of that could be faster for me. But we must also focus on our pathway zero, so the number of patients within our own organisation that could go home without that support. That is still an important area of focus for all of us across our different organisations. But we are at risk, I think, this winter if we have a 45-minute drop off and we don't have any improvement in the flows out of the organisation, of making all the things that we're doing perhaps not enough to be able to manage all of the risks that the front door holds.
No, thank you, Catherine. I've got a lot of hands up and I've not got much more time left, so just keeping things going, but I agree absolutely with what you said, Catherine. Sarah Astrid?
Thanks. No, I was just going to comment, Catherine. I think it is really powerful to do the walkarounds to see patients in the temporary spaces. Last year, really impressive that we've had such a low level of complaints. It does show, it backs up what we've talked about here with quality. But I think I just, Robin's comment is just the one that I wanted to pick up on, that this isn't business as usual, and that we shouldn't see this as business as usual, even if we can provide good quality care in those temporary spaces. So it's just making real clarity to that, to our staff and to our public. And lastly, sorry, we mustn't forget, I think, and how we do best communicate with primary care, speaking as a primary care clinician, to alert them to all that we're doing, the height of the problems that we're facing as acute hospitals, and actually what part our primary care colleagues can help to play in holding. I know we hold a huge amount of risk, but continuing to hold that risk and yet being supported by our hospital colleagues when we need it.
Yeah, no, well said, Sarah. Thank you, Julie.
Just a couple of things just to add to what Catherine has said. When we did our walkabout, there were two particular types of patients. I certainly spoke to somebody who had their daughter with them and were able to actually advocate for them, but we also spoke to somebody who had no one with them. And I think we have to be mindful of that. There was a difference between those two conversations, and I'd ask people to be mindful of that. And also Catherine's point and Sarah's point about working with place and the community. I'd be particularly interested to hear about when we evaluate the benefits of the Y community referral hub. It was the one area that was really different when you looked at those winter plans. So I think it would be really useful for us to hear that as a group.
Okay, great. Thank you, Julie, and good observation. And Sarah Shingler?
Thanks, Russell. I just really wanted to highlight that the temporary escalation spaces are one thing, when we're placing patients in a corridor or as an additional on a ward, but it doesn't quantify or kind of outline the full risk that our EDs are facing. So in our, certainly in our waiting rooms, we have patients waiting on chairs for up to 24 hours, either to get into majors or for admission. Now their needs are met in the best way that we can meet them, but there's an element of risk there. And when you think about the patient experience for the patient and the families, and I'm just sitting here thinking that actually we probably as CNOs need to get back around the table to actually quantify that level of risk in line with the temporary escalation spaces, because those patients are also as vulnerable as those in corridors from a dignity, privacy and human right point of view.
Yeah, no, thanks. Glenn, then we'll move on. Glenn?
Yeah, I completely agree with what Sarah just said. I just think one of the things that strikes me, though, when you look at that, the total number of A&E attendance data across the 4 trusts, bearing in mind Worcester has 2 EDs, how similarly sized those EDs are, and there's probably greater opportunity for us to benchmark. I'd be particularly interested on cost benchmarking chief finance officers on this one, because I think one of the things I've seen is that we're holding more patients longer in our A&E departments and actually increasing the size of our A&E teams to do so. And I wonder whether that might just give us a little bit of impetus to look at whether we could let shift some of that investment into some of these improved discharge or admission avoidance pathways. So could we do a bit of that, please?
Yeah, no, thank you, Glenn. Well said. I'd just like to make a few points. The first is to thank all of our frontline staff who are coping with the enormous stress of day in, day out, 24 hours a day, 365 days a year, coping with the pressure cooker experience that our UECs are having. I'd also like to apologise to patients and their families who are experiencing unacceptable delays in our A&Es and boarding experiences in our temporary escalation spaces. I would say to those patients and families that I think what you have just heard would be some of the best elucidation of our plans to manage this unacceptable situation as we approach the winter. So teams, thank you very much. For me, the issue is, what's the root cause of all of this? And I do get frustrated. Members of the public may have heard us talk before about the point prevalence studies that we do, which at its simplest are one-off snapshots occurring at least once a year across all of our geographies as to how much the system could save if patients were in the right place, and then nets off the situation. Across our 4 geographies, there is something like 30 or 40 million pounds a year to be saved of taxpayers' money if patients were in the right setting, in the right place. And almost always, that is about getting home as quickly as possible. And we need to do a better job as a system of supporting social care to allow them to take people out of the most expensive setting, which is a hospital, which is roughly £400 a day, and put them into a more effective, healthier setting, which is cheaper. And so I would really appeal, given all of the issues on the 10-year plan that are being considered, there is some common sense flow analysis done using point prevalence studies. And Jane refers to it in the chat box about the challenge of private providers in social care. To be honest, as a patient or a family member, I don't give a monkey's whether the service is being provided by the private sector or by the public sector. I want to be in the sector that's right for my condition. And I don't want to be sitting in an A&E for an unnecessary long amount of time. We need to do a better job at systems as to making sure that the most cost efficient bits of the delivery of healthcare are funded properly. And almost always that means finding more efficient ways of getting funds to flow to care at home. So team, thank you for your hard work. There's an appeal from me just to really use the point prevalence work, because there are tens of millions of pounds to be saved just for making sure in our little bit of England by getting people into the right healthcare setting. So hopefully that's been a worthwhile discussion. Please carry on your endeavours. Please thank all of our frontline teams, but an appeal for those who are on a higher pay grade than me to please sort out the funding flows so that we are able to support social care and get people into the right care setting faster and stop wasting taxpayers' money. Now, moving on then to another challenge we've got, which is a deep dive into productivity. and over to my Chief People Officers. So team, over to you.
Thank you, Chair. I will just kickstart our session today looking at workforce productivity, and then I'll be ably assisted by my fellow CPOs as well, Sarah and Jeffrey, who are on the call. I'm happy to take the slides I've read, but I thought it might be useful to just pop on the screen the slides so we can just point out some of the key detail as we go through. Hopefully you can all see those slides as well that are on the screen now. The data set that we've looked at spans back over an 18-month period. People data KPIs don't particularly usually change rapidly or to any great extent month by month, but over the 18-month reference period, you can really get a feel as to the sense of travel and direction that we're going in. And I want to share with you, first of all, one of our key areas of focus around the reduction in agency spend. What we can see from the data presented is that we are in a better position to where we were 18 months ago. However, it needs to be said, we do need to move further and faster if we're going to be able to achieve a reduction to anywhere near the levels that the NHS ICS systems need to get to, which is at the 3.2% mark. We can see there between trusts and we can see that direction of travel, but it is gradual, and we'll come on to, as we go through some of the other people indicators, the factors that really contribute to this difficult picture. But I think it's worth noting that the West Midlands has developed a medical agency cluster that are a group of organisations working together to really try and tackle some of the rate cards and agency rates, particularly for medical locums, to try and book some of these trends as well. And it's fair to say that we can expect much more scrutiny from our regulators in this area in terms of progress on this, as well as our individual respective boards as well. And another, I think, good news story here really is that steady downwards trajectory in turnover. So really pleasing to see that less people are leaving our trusts. And this is fairly consistent at the moment in terms of where other trusts are as well. We have seen this slight decline in turnover over the past few years. The NHS long-term workforce plan, whilst it is very vague in terms of the specific details for individual systems and trusts, it does give us a flavour of the pressures that are coming over the next 10 to 15 years. And that tells us that we still need to be moving much more towards the 7.4 to 8.2% range of turnover. So that, compared to where we are at the moment, just shows the direction of travel that we need to maintain in supporting people to stay with us and thinking about those flexible options. So those approaching retirement maybe have other options to come and stay with us on a flexible basis rather than leave altogether, and that we keep those people with us developing careers as successfully as we can. And we see here as well, and this is a slightly more difficult one to interpret, this set of data, but we can see here that our vacancy position is again more favourable when we compare it to where we were 18 months ago. This is a challenge of looking at this in a generic way, because we don't necessarily see where those hotspots are, and we do know there are those shortest professions where we need to do more in terms of career development, working with higher education institutes to make sure that we've got that steady feed of people into those professions. And one of the other trends that we also know doesn't neatly translate is that even though we've seen a reduction in vacancies, we've not necessarily seen that corresponding reduction in temporary staffing reliance either, because of that extra demand and that extra capacity we're trying to create. We know that is a challenge too. So those trajectories don't always neatly line up. One of the other contributing factors to our general performance, productivity, and particularly that agency and bank reliance as well, is when we look at staff sickness. And for this, I don't think many of the people, certainly in this meeting and people possibly watching, will be hugely surprised to see that staff sickness hasn't really shifted that much. We haven't been able to make quite the level of progress on this that we would wish at all in this area. We've seen peaks and troughs as we've gone through the year, and we've seen peaks in sickness that individually as trusts we've been able to recover from. But this still feels quite precarious in terms of the general health and well-being of our workforce. We see a significant number of colleagues that are off from work with anxiety, stress, depression, or psychiatric illness, not always related to work, often a very complex picture that forms for individuals and leads them to take time off work. And we're seeing across the NHS as a whole, that has become one of the most significant reasons for people taking time off work. The lack of movement around this is despite the fact that we have increased our offer to people, so making sure that there is a range of health and wellbeing support available to our colleagues. But there's clearly still more work to do here, and more focus to really take on making sure that we look after people well enough and we support people to stay in work or return to work in a way that keeps them safe and well. And then the final set of data. Now this one is a difficult one in terms of how we compare trust against trust within the group. So 3 out of 4 of our trusts use track software, with Worcester being the exception. And track software is a recruitment software, end-to-end recruitment software that many organisations across the country do use in order to manage their recruitment. It does give an ability for trusts to be able to cut some of the performance data down in a way that NHS Jobs doesn't. What we can see here is a relatively stable picture in time to hire. Worcester does show as an outlier on here, and that is because of the nuance of the fact that we don't use track. So where we see our time to hire looking exceptionally high at 85 days there, that is skewed by the offer to students and some international colleagues that have a much longer offer period, that we can't cut the stop and start button, so to speak, on the time to hire metric in the same way. What I would share here, I think, is for those that are not familiar with NHS recruitment, or members of the public that are interested in these timescales, which to somebody who's not experienced NHS recruitment do look fairly lengthy, is that there is a specific set of standards that are very exacting, very critical, that we are required to follow to make sure that people safely join the NHS workforce, and that people have the sufficient background checks, right to work checks and qualification checks, etc. That remains an important priority for us, and it's something that we won't compromise on as well. So despite there being challenges with the delay sometimes to be able to onboard people, for us that safety is absolutely critical in making sure that people do successfully get through those checks, and we bring them on as soon as we can as well. And a couple of areas I just wanted to highlight. We've got some slides now that just talk about the individual trusts, and I'll highlight Worcester before passing over to Sarah, who do George Eliot and Swift, and then Jeffrey for White Valley. The key focus areas that I really wanted to mention for Worcester are, in particular, medical agency reduction. We've seen some good success in nursing agency reduction, and now we are much more focused in that medical agency and locum area as well, in terms of the improvements we can make. We know there is more we can do there, and we are having those conversations in depth with our divisional colleagues as well to try and risk assess the moves that we need to take to reduce that further. And the other thing I wanted to highlight is our very recent decision as of last week to invest further in our occupational health resource, recognising that change in demand that's come through our occupational health departments around some of the sickness absence, but also some of the wellbeing needs for those that remain in work but are struggling with health conditions and trying to work whilst they deal with those health conditions too. So they're our key areas of focus. I'll hand over to Sarah now to take you through the next bit.
Thanks, Ali.
Oh.
Sorry, thank you. So if I start with George Eliot, if you can move the slide forward, please, Ali.
So one of the things that we're really proud of at George Eliot is all the work that we've done to reduce our agency usage. So we have had no off-framework agency in nearly 18 months, and we've had that consistent reduction in our agency spend. Apologies, I think it's an older version. We had a spike in August 2024 due to reduced bank availability, which meant that we used some agency medics instead. But come September, we saw that reduce back down below 2%. So that downward trajectory is continuing. We have seen a consistent reduction in our turnover. It remains below target, but it is higher than other trusts within the group, and we're doing some very targeted work on our staff experience and therefore staff retention. Our overall vacancy rate has reduced. However, we saw a big increase in April following a piece of work to align ESR, which is our workforce system, and Integra, which is our finance system. So we now have a lot more confidence in the data that we have. We also increased our establishment, particularly for domestic assistance, which caused that increase in our vacancy rate. But again, we are seeing that reduce as we appoint to those posts. And we have had some successful recruitment into some of our key posts, which we were using a high-cost agency for, so including paediatrics and ophthalmology. Our sickness absence does remain above the target of 4%, but it is comparable with the national average for sickness. As Ali said, there is a regional agency rate card that we have implemented, and that's for medics. We are now working as a region on implementing an agency rate card for nursing as well. We're also working with NHSP, who manage our bank, to stop all agency use above price cap. We're also looking at our recruitment processes. We can see that our time to hire is higher at George Eliot, and so it's what can we learn from others within the group to get people into post more quickly. We've revised our sickness absence management policy, very much focused on staff well-being and particularly on mental health and musculoskeletal, which we know are our highest reasons for sickness absence. And we've implemented the role of the People Promise Manager, who has a clear action plan to improve our staff experience and staff retention, with a particular focus on improving our flexible working offerings. And finally, we're working across the system on our workforce planning, something that historically we have not been great at within the NHS. And actually, it's looking at how locally we implement the long-term workforce plan to meet our future staffing needs, so working in collaboration with our higher education institutes to look at our future needs. If I move on to Swift, then we have seen a consistent reduction in turnover at Swift, and it remains below target, and we have very low turnover rates. We've also done a lot of work to significantly reduce our agency spend. It is still just above the NHSE ceiling of 3.2%, but actually we have successfully recruited to some locally employed resident doctor roles, and that again will help support that reduction in temporary staffing. Our time to hire has reduced significantly, and we have a low overall vacancy rate. Sickness absence is an area of concern, although it remains comparable with the national average. And therefore, one of our key actions is review of our sickness absence management policy. It's not been reviewed since pre-COVID, and there's quite a big piece of work to make sure that actually it's fit for purpose, having that focus on early intervention, having clear process for managers, but very much focusing on improving staff well-being, as well as managing absence when it happens. Again, implemented the regional agency rate card. We have the People Promise Manager working across the two trusts. And then Nick Rees is undertaking a piece of work to review internal bank rates as well. So making sure that those remain attractive for colleagues to pick up additional shifts, whilst also being consistent with system partners. I will hand over to Geoffrey.
Thanks, Sarah. So as you can see from this slide, we are also taking similar actions to the ones covered by Sarah and Ali. And we also working very closely with our chief medical officer and our chief nursing officers. So we having fortnightly review meetings looking at the reasons behind the use of high agency, because reducing agency spend is our key priority. So we actively supporting the chief nursing officer, chief medical officer in doing that as well. We also conducting regular reviews to ensure that our workforce KPIs are in line with NHS-wide KPIs. And we know that Swift currently are amongst the best in terms of KPIs. So our ambition is for us to share best practice, which we are doing, to ensure that we can all also be amongst the very best in terms of KPIs that we report on. So HR teams do share that best practice. Why Valley will be part of a national NHS-wide study looking at sickness absence across the NHS. That process will be kicking off, should have started in October, but it's been delayed till January. So that will run for 12 months, and all the parts of the group, colleagues of the group, will also be participating in that study. We also understand that you cannot look at workforce productivity in isolation. So we are putting things in place in terms of staff engagement, terms of trying to look after the health and well-being of people and making sure that people have a voice. So the whole freedom to speak up agenda is also something that we all focusing on. So all in all, the board can be assured that we are sharing best practice. We are benchmarking our workforce productivity metrics to NHS-wide performance indicators. And we have this aspiration, or the intention is for us to be across the group amongst the very best in the health service. So pushing the productivity side whilst also engaging with staff and putting things in place to look after their health and well-being, because we understand that without looking after your staff, they can't really look after your patients. So hopefully we've covered the key aspects of what we're doing, and we're happy to take any questions.
That's great. Thank you, Jeffrey, and thank you everyone for your hard work. We are running a little bit late. Glenn?
Yeah, I mean, just quickly, I mean, thank you for the chief people officers for the work they're doing on this and other colleagues, and also in the background, they're all pushing very hard on staff survey response rates, but there could only be one winner, but I'm not sure how they're going to deal with it if they're not a winner on that one, because I know they're all working hard. But that will give us some more clues on how we can address some of these things. And I think if we separate out some of the different staff groups, it feels like we've made some really good progress on nurse agency reduction. It feels like there's a little bit more work to be done on medical. I think the other thing that came out of there for me is this, we've mentioned occupational health and support for staff, and I just wonder whether that's something we could look again at, whether there's a group-wide opportunity to strengthen that.
Yeah. Any other questions or perspectives, colleagues? I guess I'd just like to make one, and I don't mean to be a dog with a bone, but I'm a dog with a bone. I do think a lot of our sickness challenge is staff just feeling often emotionally or physically exhausted with the stress and pressure cooker environment that they're often having to work on. And that is exacerbated by our problems in UEC. And our UEC goes back to flow efficiency. So this issue of medically fit for discharge and getting the discharge processes to work with our partners. If our flow efficiency was working well, they could find a bed when they want to find a bed for a patient out of UEC. The stress levels would go down. And so I would just really advise my execs teams not to allow this normalisation, which I fear is creeping within the NHS of, well, we can't really do much about the relationship with social care and partners. We can't really do anything about the long waiters. We can't really do anything about, the temporary escalation procedures, because we just have to accept they're going to be necessary. So we'll go for the best standards of care around the protocols. The root problem is we've got too many patients stuck in the acute who shouldn't be in the acute. If collectively we can sort that out, we reduce the pressure by increasing the flow efficiency. Really great presentation, guys. Thanks for your hard work. And will therefore segue, while still hearing your lovely voices, into the gender pay analysis. So back to you guys.
Thank you. So I am going to start this one. I am mindful of time, so I would plan to take the slides as read and just pull out some of the key points. So all NHS trusts are required to publish an annual gender pay gap report, and this is based on the pay indicators set out by the Government's Equalities Office. In line with all NHS trusts, the workforce at the 4 trusts in the group is predominantly female at just over 80%. But when we break that down by pay quartile, you can see that for most trusts, the ratio of females in the lowest pay quartile is higher than in the upper pay quartile. So that means that proportionately, women are more likely to be employed in the lower banded roles. The only exception to this is Swift, where the ratio of women in the upper quartile is reflective of the overall ratio of women in the organisation. When we look at both the mean and the median of pay, we can see that across all 4 trusts, men earn a higher rate of pay than women. I think it's really important to remember that this is not an equal pay report. So this isn't saying that men receive a higher rate of pay than women for doing the same job. What it does indicate is that men are likely to be in those higher paid roles than women are. As you can see, for 3 out of the 4 trusts, the pay gap is reducing, but for George Eliot has increased. And one of the main reasons for that is because George Eliot has all the soft FM services in-house. So all of our domestics, our catering, etc. in-house, and they are predominantly Band 2 roles. And we have also recently increased our establishment of domestic assistant posts. If we move on to the bonus pay, this is only applicable to consultants, and actually this will gradually be removed in line with the revised terms that have been agreed as part of the consultant pay deal. So in terms of the actions that were taken to address the gender pay gap, at George Eliot, we've developed our management and leadership programme, and we're monitoring that to encourage as many women as possible to participate in that and to progress into those senior leadership roles. We're also working with our clinicians to encourage our female clinicians to move into those clinical leader, clinical director roles. We're working with our staff networks to promote the opportunities that are available for our colleagues to access, and we're working on the Levelling Up programme to support our internationally educated nurses into senior roles within the trust. We have developed an inclusive recruitment toolkit, which we are promoting, and we've reviewed our recruitment training package to make sure that we have consistency between applicants and equity for all. And we're also looking at the staff who are accessing learning opportunities so that we can determine the ratio of learners by gender to see if that is something else we need to work on. For Swift, the pay gap is closing, but that doesn't mean that there's not more work to do. So again, we're working with our staff networks to promote all of those opportunities that are available. We're providing training to recruiting managers to reduce bias in the recruitment process. And we're again supporting our international nurse recruits into senior roles, and we're really promoting flexible working opportunities to support women to progress despite having disproportionate carer responsibilities. I'll hand over to Ali.
Thank you, Sarah. So for Worcestershire hospitals, our actions are really focused around that career development conversation. This isn't something that is exclusively for our female colleagues. However, we do make sure that access is available and that our networks are very cited on that inclusivity as a priority as well. Trying to make sure that we are promoting apprenticeships and making sure that flexible working offer is really brought home to people. Again, that's not exclusively predominantly an issue just for our female colleagues, but we do know that predominantly our female colleagues will find themselves also juggling those caring responsibilities as well as their career ambitions. So trying to make sure that we really major on those flexible working opportunities, flexible apprenticeship opportunities, and making sure that we have that coaching support for people as they develop their career has been really important to us and remains an area of focus as we go forward as well. I'm conscious of time, so I'll hand over to Jeffrey next.
Yeah, thanks, Ali. Well, as you can see from this slide, it's also very similar to the actions taking place across the group. So we're working closely on key actions that we believe can help us address the gender pay gap. And our position as a group is very similar to what you find NHS-wide, and that tends to be because you got lots more male colleagues in the medical and dental profession, so it tends to be what skews the figures up. But with the flexible working approach and all the different things we're bringing into the equation, trying to support our female colleagues, we are confident that over the next few years, you will start seeing a shift, especially now with no more clinical excellence awards. So with that clinical excellence awards being stopped, over the next few years, you would try and see some more parity in terms of the gender pay gap. So all in all, we are sharing ideas, we're sharing good actions, and we'll continue doing so over the coming years because we know it's a real concern, certainly in the NHS. The other final thing I would say is the fact that the new Labour government are also now talking about the ethnicity pay gap. So it's likely that that will be mandated by 2026. So we'll have started looking into that and just waiting for the national template and the national formula to come out, which should be coming out within the next few months or so. But once that is in place, we'll then have to start reporting on the ethnicity pay gap as well. So we'll keep on working on this, and you can be assured that from the actions that we presented, we've taken the right steps in addressing the gender pay gap. So I'll end there for now, and happy to take any questions.
Yeah, no, great, and thank you, team. Some important points put into it. I guess just to start us off on this, Julie's put an important thing into the chat box. If someone could have a look at it about the last presentation, I do just worry that we're focusing on gender, and we don't focus in a similar way on other areas where there's a need for equality and equity, particularly around BAME and particularly around disability. Because it's the roles that get the levels, and as you've all said, it's that there's just a preponderance of men in the more senior, higher paid roles, which is leading to the analysis. I would just encourage us as we go forward, I know we touched on it partly in the presentation, is to take a fully rounded approach to the issue of equity and equality of opportunity and encouragement. That it isn't just talked about as a gender issue. Do colleagues share my desire to sort of broaden the perspective, Glenn?
Yeah, and our wider kind of EDI reporting does pick those issues up. I mean, obviously the gender pay gap is a specific directive we should be looking at, and it's good to see some progress, but clearly a lot more to be done.
Yeah, it's just, I know it's one of the things we need to report on. It's just feeling a bit old, you know, sort of 5 years, 10 years out of date. Whereas, you know, I want us to ensure that we are really focusing on the broad gamut of EDI in the very positive way we all want to embrace it. Grace has popped something into the chat box. Any other comments colleagues want to make? I think some comments coming on what I just said. Okay, well, super. Keep us briefed on that, guys. And just whilst I'm on the subject of EDI and neurodiversity, there was a very interesting interview I saw with a senior business leader who was talking about the fact that being neurodiverse can be an extremely powerful characteristic in very senior complex organizations. So I would just like to say to anyone who might be watching this who's maybe got ADHD or has maybe got Asperger's or whatever, or dyslexia or whatever type of neurodiversity. Some of the most able people I've ever met have been neurodiverse. So I would just encourage you to try and fulfill your dreams and not allow some challenges to limit your own aspirations or life journey. I think we've got one item for approval, which is a Foundation Group Board calendar of meetings for next year. Sarah, shall I just take this as read?
Yes, please, and to seek approval, Russell.
Of course. If you're not happy to approve this, could you please raise a digital hand? Okay, I think that's duly been signed off. Any other business, colleagues, before we go to questions? If you've got any other business, could you please raise a digital hand? So just in terms of questions for members of the public and governors, just a point in terms of protocol. It is very helpful if you can try and get your questions in early, and that just allows us to address them. And there will be some questions, and we've got a couple today, which are probably best handled not in a board meeting, but through a freedom of information request. But we will always give you the opportunity to ask you any question you like, which I think is incredibly important for all public bodies. So without further ado, Sarah, do you want to read out the questions you've received, please?
Thank you. So Roger Lloyd is a governor at Swift. He's submitted 2 questions. The first is, whilst mention has been made of intelligent surveillance conveyancing, there is no mention of the risk associated with the implementation of the 45-minute protocol. How is it intended to mitigate this risk? And I believe Jack Foster's going to answer the question.
Yeah, just before you go in, Jack, I think we've discussed this quite a lot today, hopefully. But Jack?
Yeah, obviously it represents a huge risk to Swift and the other members of the foundation group. I guess our performance against the 30-minute standard is very high, which in itself kind of mitigates some of that risk. Last week we only had 1 ambulance that waited over 30 minutes. In terms of the mitigations, I think we've discussed a lot of those both this morning and this afternoon in terms of that work and development going on in that admission prevention sphere and in the facilitated discharge, because if we get the flow right throughout the hospital, then we should have the capacity to offload the ambulances. Some of the mitigations we've got in place, obviously the call for convey, to try and again deter the ambulances from coming in, to try and to stream them to the community wherever possible. It's going to be a significant mitigation for us. We internally at Swift, we discuss this risk and things like this on a daily basis at our silver calls, and there's support offered to the site team, to the on-call teams, in terms of how to manage that, in terms of potentially using those escalation spaces, or how we're liaising with WMUS if we don't think it is safe that they do a rapid offload. So that's another forum where we've got that kind of support mechanism for our staff at the front line and our on-call teams in those instances.
Great, super, thanks, Jack. Sarah, back with you.
Thank you. So then Roger asks that with COVID still circulating in the community, what is the prevalence of long COVID in the community and how is this being addressed? I think Jack's going to also answer this one. Thank you.
Earning your salary today, Jack.
Indeed. In terms of the prevalence of long COVID in the community, I reached out to Duncan Vernon, public health consultant, who said there's not much out there at the minute, but I have posted in the chat before a few comments there, a report from last winter around COVID and some long COVID implications, and there might be a similar report over this winter following further waves of COVID, but data isn't overly robust on the levels and prevalence of long COVID in the community. In terms of what we're doing internally at Swift, we're still running a bi-weekly post-COVID MDT. Patients are triaged after 2 weeks. They're then brought into MDT between 4 and 6 weeks, where they're then able to access a range of professionals. So that's a physiotherapist, dietitian, psychologist, occupational therapist, high intensity therapist, respiratory medic, and a neuro rehab consultant are available through that MDT. We have seen referrals reduce significantly since COVID. So I think in 21-22 we had 348 referrals. So far this year we've only had 65 referrals, so we're seeing a drop off in referral levels to that, but that team are doing a huge amount of kind of education and training internally with wards and departments, and especially with primary care and PCNs, to make sure those referral pathways are known and that are open, so that if this is picked up out in the community, there's the awareness of the service that we're still offering.
Okay, great, thank you, Jack. Sarah, any more from you?
Not from me, thank you.
Okay.
Gwynny's got.
Yeah, good. Gwynny, you've got a few. So
Yeah.
do you want to read out?
Yeah, we have.
And say what we're doing with them?
Yeah, so we have one from the Patient Forum for Worcester Royal about the TV screens in the emergency department waiting room not giving the up-to-date or accurate information. So I think Chris has been working on a response for that. And we've also had questions from members. Do you want to do that one here?
Yeah, just do one at a time. Chris, so what are we doing about the accuracy of the data in the UEC?
So I think Rebecca Brown's prepared a response to that, Gwenny, rather than myself.
Okay, so
Yeah.
Rebecca on the call.
Yeah, I'm here, Bristol. So this is our screens that show how long it takes to see a GP, to go to triage, to see an ED doctor, and to see a specialty doctor. It's live data. It's on a 5-minute refresh time. We don't know what period the patient was talking about, but it could have been that the data was delayed for a reason, or it could have been that some of the people in the waiting room were people with patients, so therefore not counted on the screen, or perhaps, unfortunately, patients who already had a decision to admit but were waiting in our waiting room, as Sarah Shingler referred to earlier.
Okay, but in your view, the data on those screens is accurate?
That's right, and we did have a few checks yesterday, Russell, in advance of this meeting, and went down and did a manual count as well. So yes.
Okay, thanks, Rebecca. So, colleague from the Patient Forum, if you want to get in touch with us again, just if you can go to Gwynny and then she can feed it to Rebecca. Back with you, Gwynny.
So we've had another information request from a member of the public about the complaint system at Worcestershire. It's quite a detailed information request about the complaints policy and the extent to which we're compliant with it and with some complaint standards. So we've suggested that might be dealt with via FOI, but also we can talk about it at the Worcestershire board meeting.
Okay, that's great. If we can make sure we've got that ready for the Worcestershire board, that would be super. Thank you.
Similarly, another request for information from a member of the public about the learning from deaths policy and the requirement to report details of deaths in board meetings. This is also about Worcestershire Hospital. So again, there's a bit of information request here about data. So again, probably best to be dealt with in a similar way.
Okay, super. Thank you, Gwynny. Anything else from you?
Thanks.
Okay, and as we're now running sort of on time, if any members of the public who are in the meeting want to ask a question now, please raise a digital hand. Okay, I can't see any digital hands going on. So our next meeting of the foundation group will be in February, I think. So look forward to seeing you then. We're clearly running into winter, so we will be obviously having our individual boards, but focusing on delivering the best possible care that we can. Hopefully, members of the public who are watching this meeting in the future will gain some assurance about the phenomenal efforts that our executive teams in particular are putting in to ensure the best possible care for you in a very challenging set of circumstances. I would ask members of the public, if you are offered a flu jab, please get it. If you're offered a COVID jab, please get it. Please only come to the emergency department if you really need to, and please reach out to primary care, pharmacies, GPs whenever possible to try and take some of the pressure off of our hard-working emergency department teams. Take care, everyone, and I look forward to seeing colleagues in the confidential board, which we will start at 3:30. So 10-minute break, and I will see you in 10 minutes. Thank you very much. Take care.